Hello everyone. Our today's topic is titled Heart Failure Care in SNFs, When More is More. The objectives of today's presentation include listing requirement for an evidence-based heart failure care medication regimen, analyzing a medication regimen in a skilled nursing facility patient to assess for harmful polypharmacy, and to use strategies to deprescribe in a heart failure patients in the SNF setting. Let's consider Mrs. Smith, who is admitted to a skilled nursing facility. She is an 81-year-old white female with high blood pressure, dementia, and heart failure with preserved ejection fraction. She is admitted to your facility for rehabilitation. She requires 2% assist for transfers and can only walk 30 feet with the use of a walker and 1% assist before she gets very short of breath. This patient is slightly confused and overall takes 12 medications, some of which include furosemide, hydralazine, metoprolol, and amlodipine. The nurse on call who is admitting this patient calls Dr. Patel, the primary care provider, who reviews and asks to the nurse about the medical regimen and if it is evidence-based. Let's just think about which medications have been shown to reduce mortality in heart failure patients who have preserved ejection fraction. Dr. Patel actually informs the nurse that none of the medications on the regimen have been shown to reduce mortality in patients with preserved ejection fraction. He does inform the nurse that these medications do improve comfort in the patient but may have unintended consequences such as hypotension and renal failure. He advises the nurse to continue furosemide to help with patient's edema and shortness of breath. He also asks the nurse to weigh the patient on a regular basis and call him if the weight increases by 2 pounds overnight. On day 3, the nurse calls Dr. Patel because the patient has gained 6 pounds weight overnight. Dr. Patel is worried about the patient and recommends to double the dose of the medicine. He also confirms that patient is taking low-salt diet. And finally, also orders the use of knee-high stockings because of increasing lower extremity edema. After a few days, the nurse calls Dr. Patel back in the night because Mrs. Smith is finding it hard to breathe. Her vital signs are still stable, but her pulse ox has dropped down to 80%, even with the use of 4 liters of oxygen. Dr. Patel is concerned because he feels that patient needs to be rehospitalized. And he's also worried because this is the 3rd patient he is planning to readmit this month. And he was also worried if his staff indeed are providing good care to his patients. Are his concerns legitimate? Or has he been providing the best care he could have? The next morning, the facility medical director, Dr. Thomas, is asked to review the patient's chart. Dr. Thomas discovers that indeed the staff did provide excellent care for this patient with heart failure. He also did notice that Dr. Patel was unable to review all medications in detail and address harmful polypharmacy in Mrs. Smith's care. Detailed review of medications quickly shows that she is taking potentially harmful medications, including a daily dose of ibuprofen to control her arthritis pain, a dose of Actos to control her blood sugars, use of amlodipine for her blood pressure, and she's also using a nightly dose of quetiapine because of her episode of delirium while she was in the hospital. What is the best approach for Dr. Thomas to take? Here are some options. As you would agree, the first two options may not be appropriate at this time. Blaming an individual for a systematic problem would not result in any meaningful benefit. Similarly, the refusal to accept patients with polypharmacy does not appear to be the right choice. The third option makes sense, but in this case, the facility already has been performing daily weights. The final option seems to be the most suited one, which requires for Dr. Thomas to use strategies that can systematically address harmful polypharmacy in his facility. Polypharmacy is defined as more than 5 medications in a patient and has been shown to result in significant risk of adverse events in older patients. Literature shows that 1 in 5 drugs used in the elderly may be inappropriate, and that adverse drug events occur in at least 15% of older patients. These adverse events may also include disability, hospitalization, and death. It has also been shown that pharmacist-led review of harmful medications may decrease risk of avoidable hospitalization in patients with heart failure. Evidence also shows that deprescribing is feasible, safe, and beneficial in older patients. Recent evidence published in Journal of American Medical Association provides excellent algorithm to use deprescribing strategies. It recommends going through a stepwise approach, which includes step 1 to perform accurate medicine reconciliation. Step 1 recommends performing medication reconciliation to get to an accurate list of medications on admission and discharge. Step 2 requires for the clinicians to consider the extent of overall risk of drug-induced harm from polypharmacy. For step 3, clinicians are required to assess each drug for eligibility for discontinuation based on many potential reasons. These include that medication may not have any valid indication at this point. The medication may be a part of a prescribing cascade. An example of such a cascade includes use of Lasix or furosemide to address the leg swelling caused by a medicine like amlodipine, and then the use of potassium to address hypokalemia that results from the use of furosemide. It has been shown that addressing such a cascade may lead to discontinuation of many medications that may be potentially harmful. Other reasons for deprescribing may include that a drug may be actually harmful or may be of limited benefit, or there may not be any more role for this medication for prevention at this point, which may be actually the case in many older geriatric patients with advanced dementia in the skilled nursing facility setting. Step 4 requires for the clinician to prioritize the drugs for discontinuation, and final step, and probably the most important step, requires the clinician to implement systems for ongoing monitoring for the patient who has gone through deprescribing. Such monitoring requires to assure that patient is not having recurrence of any of the symptoms. Facility level quality assurance and performance improvement is very important to address systematic issues within a facility. In this case, Dr. Thomas plans to partner with the facility leadership and the consultant pharmacist to implement systems of quality improvement to address polypharmacy review. He implements protocols for detailed medication appropriateness review on admission. He also provides education materials for the staff and family members around polypharmacy and e-prescribing and the benefits of such approach. He educates the nursing staff and implements protocols to monitor patients after de-prescribing has been performed. And he also sets up metrics for success of this project. So Dr. Patel ends up learning a lot from this episode. He learns that heart failure is one of the leading causes of readmission in skilled nursing facility patients. He also learns that polypharmacy may lead to harm in heart failure patients. He also recognizes that there are evidence-based and systematic approaches to de-prescribe harmful medications in heart failure patients in the skilled nursing facility setting. He also learns that a quality assurance and performance improvement approach requires to identify a problem, review the associated data, and implement interventions that can improve a selected set of metrics. This leads to the conclusion of this presentation.